Hey you, welcome back to the deep dive. You know that feeling when the dentist gives you a shot and suddenly a whole section of your face feels like it's decided to take an unscheduled holiday? Or maybe you've experienced that precise numbing before a minor procedure, allowing you to remain completely aware but utterly comfortable. It's almost magical, isn't it? But behind that seemingly simple sensation of numbness lies an incredibly intricate world of chemistry, biology, and precise application. Today, we're taking a deep dive into something that touches so many of our lives, often without us giving it a second thought: local anesthetics. Our mission today is to truly understand the ins and outs of this topic together, digging into the insights from your sources to build that, elite professional level of understanding. We're going to unpack this fascinating corner of pharmacology, moving beyond just numbing medicine to truly grasp how these agents work at a molecular level, their surprising history, the clever nuances of their chemical structure, and the incredibly diverse ways they're used in clinical practice. Get ready to uncover some fascinating science. Let's dive in. All right, let's unpack this from the very beginning. When we talk about a local anesthetic, what is its fundamental job and how does it accomplish it at the most basic level?
Right. At its core, a local anesthetic acts like a temporary switch, really, turning off nerve signals. When applied in the right concentration to nerve tissue, it reversibly blocks the action potentials responsible for nerve conduction.
Action potentials. Those are the electrical signals, right?
Exactly. Think of an action potential as the electrical signal that nerves use to communicate. It's how your brain tells your finger to move, or how your finger tells your brain it just touched something hot. What's truly ingenious is how they do this. These drugs achieve their effect by binding to a specific receptor site, right within the pore of the sodium ion channels in nerves.
Sodium channels, okay.
Yeah, the NEP plus channels. They essentially put a physical stopper in the channel and block the movement of sodium ions through that pore.
Like a temporary plug.
Precisely. And this reversible aspect is absolutely crucial. It means nerve function recovers fully. This isn't like cutting a wire. It's more like hitting a temporary pause button. The ions, especially sodium, are vital for those electrical nerve impulses. By blocking their entry, the signal simply can't generate or move along the nerve.
It just stops it cold.
Temporarily, yes. And what's remarkable is that this blockade can affect any part of the nervous system and every type of nerve fiber. So if it comes into contact with a nerve trunk, it can temporarily cause both sensory paralysis, meaning you don't feel anything,
Right.
and motor paralysis, meaning you can't move that part in the affected area. It's a comprehensive yet completely temporary silencing.
That fundamental ability to pause a nerve signal is truly remarkable. But the journey to understanding and harnessing that power, well, it has a surprisingly long and winding history, doesn't it? One that actually began not in a sterile lab, but with a fascinating and perhaps notorious plant. Isn't that right?
Absolutely. The story of local anesthetics actually begins, quite serendipitously, in the late 19th century with a plant that, as you said, carries a lot of baggage today.
Okay.
The coca shrub, Erythroxylon
Smoke
coca.
that.
For centuries, Andean natives chewed alkali extracts of these leaves, primarily for their stimulatory and euphoric actions, an ancient tradition linked to, endurance and combating fatigue at high altitudes. The scientific chapter truly began in 1860, when Albert Niemann successfully isolated cocaine from the plant.
Right.
He then famously tasted his newly isolated compound and immediately noted that it numbed his tongue.
Tasted it. Wow.
Yeah. This simple personal observation, almost an accidental discovery, truly marked the beginning of a new era in pain control. Fast forward a couple of decades, Sigmund Freud.
Freud?
Yes, Freud.
Yeah.
Known for his later work in psychoanalysis, he actually studied cocaine's physiological actions quite extensively. And it was Carl Kohler in 1884 who introduced cocaine into formal clinical practice as a topical anesthetic, specifically for ophthalmological surgery.
For eye surgery. That must have been huge.
Oh, absolutely revolutionary, allowing eye procedures to be done without the patient experiencing pain. Shortly thereafter, a prominent surgeon named William Halsted popularized its use in infiltration and conduction block anesthesia, expanding its reach dramatically beyond just the eyes. However, as you might expect, given what we know about cocaine today, its significant toxicity and highly addictive properties quickly became alarmingly apparent.
Yeah, that's the downside.
Exactly. This immediately spurred a critical and urgent search for synthetic substitutes. The pressing question was, how could we achieve this remarkable anesthetic effect, this profound reversible pain control, without all the detrimental side effects that came with cocaine? And that search paid off dramatically. The pioneering work of Einhorn and his colleagues in 1892 led to the synthesis of procaine.
Procaine. Okay, I've heard of that. Novocaine.
Exactly, often known as novocaine. This compound became the prototype for local anesthetics for nearly half a century, laying the chemical groundwork for countless subsequent discoveries. Today, the most widely used agents, which we'll dive into in much more detail, are things like lidocaine, bupivacaine, and tetracaine.
The modern workhorses?
Right, all direct products of this ongoing persistent search for safer and more effective compounds to manage pain.
That history is genuinely fascinating. It's wild to think how a casual taste test led to a whole new branch of medicine. But now that we know what they do and where they came from, let's talk about how they're built. It's not just a random combination of atoms, is it? How does the actual structure of these molecules dictate their behavior?
Absolutely not random, no. What's truly ingenious about typical local anesthetics is their remarkably consistent fundamental structure. They're designed with a precise architecture. They contain both hydrophilic or water-loving and hydrophobic or fat-loving parts. Think of these as two distinct ends of the molecule.
Water-loving and fat-loving, okay.
These two essential parts are separated by an intermediate linking group, which is key. This linker can be either an ester or an amide.
Ester or amide?
And that chemical distinction is a major determinant of the agent's pharmacological properties, especially how it's metabolized and how long it lasts. Let's quickly break down these key components. The hydrophilic group is typically a tertiary amine, though it can also be a secondary amine. This is the part that will ultimately interact with the target receptor inside the nerve cell.
Got it.
Then you have the hydrophobic part, which must be an aromatic group. This fatty aromatic component is what allows the drug to effectively penetrate the lipid membranes that make up nerve cells. It's essentially the passport that gets the drug inside.
The key to get through the door.
Exactly. Now, that intermediate linkage ester versus amide is paramount. Local anesthetics with an ester link, like our historical example procaine, are readily hydrolyzed or broken down by enzymes found in your blood plasma.
Plasma esterases.
Right, plasma esterases. This rapid breakdown generally means a shorter duration of action. On the other hand, local anesthetics with an amide link, such as the widely used lidocaine, are much more resistant to this plasma esterase hydrolysis. They're primarily degraded by enzymes in your liver.
The liver.
Particularly the cytochrome P450, or CYP, enzymes. These are a crucial family of enzymes that help break down drugs in the body. This difference in metabolic pathway is why amides generally have significantly longer durations of action.
So the linker determines if your liver or your blood enzymes break it down, which affects how long it sticks around. That's a practical difference. But what about hydrophobicity itself, that fat-loving characteristic you mentioned? It sounds like it helps the drug get into the nerve, but is there a downside or a trade-off?
You've hit on a classic pharmacological dilemma.
Yes.
Hydrophobicity plays a dual and somewhat paradoxical role. On one hand, increased hydrophobicity enhances both the potency and the duration of action.
So stronger and longer lasting.
Exactly. This is because it helps the drug partition more effectively into the fatty environment of the nerve membrane and the receptor itself. The more fat-loving the drug, the better it can slide into and interact with that crucial nerve membrane. It also contributes to longer duration by decreasing the rate of metabolism. So for performance, more hydrophobicity sounds great.
But there's always a but.
There is. The downside is that, while beneficial for potency and duration, hydrophobicity also increases toxicity. This means that the therapeutic index, which is the ratio between a toxic dose and a therapeutic dose, is actually decreased for more hydrophobic drugs.
So the safety margin gets smaller.
Precisely. In simpler terms, the gap between a dose that works effectively and a dose that causes problems becomes narrower. It's a critical balance in drug design. You need enough hydrophobicity for effectiveness, but not so much that it becomes dangerously toxic.
Finding that sweet spot.
Exactly. It's like finding the sweet spot where you get the most punch without the most peril. Finally, molecular size also plays a role in how these drugs work. Smaller drug molecules can escape from the receptor site more rapidly.
Okay.
This characteristic is especially important in rapidly firing cells, like those involved in transmitting intense pain signals. In these scenarios, local anesthetics bind during action potentials and then dissociate during membrane repolarization. This rapid binding and dissociation contribute to what we call the frequency and voltage dependence of their action, a fascinating concept we'll explore even further.
That explanation of their chemical blueprint really paints a picture of how these molecules are engineered for a purpose, almost like tiny machines. But now let's pull out our molecular magnifying glass and really see the action. How does that precise structure actually switch off a nerve signal? What's the dance happening inside the nerve cell membrane?
Okay, zooming in. The precise mechanism involves preventing the generation and conduction of nerve impulses by directly targeting those voltage-gated sodium loss channels we mentioned.
The gates.
The gates, yes. These channels are like tiny, exquisitely controlled gates in the nerve cell membrane that open to allow sodium ions to rush in, triggering the electrical signal that is the action potential. At a cellular level, local anesthetics block conduction by simply decreasing or preventing the large, transient increase in the permeability of these excitable membranes to sodium ions.
Okay.
This increase is what normally occurs when the membrane slightly depolarizes and triggers an action potential. Their action is a direct physical interaction with these voltage-gated sodium channels. As the anesthetic action progresses in a nerve, several key things happen. The threshold for electrical excitability gradually increases.
So it's harder for the nerve to fire.
Right. The rate of rise of the action potential declines, so the signal doesn't build as quickly. Impulse conduction slows, so the signal travels sluggishly. And the safety factor for conduction decreases, making it less likely for the signal to reliably propagate. All of these factors together reduce the probability of the action potential successfully propagating, eventually leading to complete nerve conduction failure.
Total.
Right. While local anesthetics can bind to other membrane proteins like potassium K+ channels, this generally requires much higher concentrations and isn't the primary mechanism for the effective conduction blockade we rely on clinically.
So it's really all about those sodium channels. And you mentioned earlier that the drug needs to get inside the cell to work. Why is that inner access so important? Can it just block from the outside?
Great question. That's a crucial detail. What's truly fascinating here is that charged versions of local anesthetics, which are called quaternary analogs.
Always charged, you mean?
Yes, always charged. They only block conduction when applied internally to nerve cells, like if you perfuse them inside an axon. They're largely ineffective when applied externally.
Ah, okay.
This powerfully demonstrates that the site where local anesthetics act, at least in their charged form, is primarily accessible from the inner surface of the nerve membrane. Therefore, local anesthetics applied externally, which is how we administer them clinically, must first cross the membrane, often in their uncharged form, before they can get inside and exert their blocking action.
So it's a two-step process: get in, then block.
Exactly. Entry, then action. Now, let's delve into the atomic detail of the local anesthetic receptor site on these Na+ channels. The major mechanism involves interaction with a specific binding site within the Na+ channel. These mammalian brain Na+ channels are complex, glycosylated transmembrane proteins, essentially large structures made up of a big alpha subunit and smaller beta subunits.
Complex proteins.
Very. The alpha subunit is particularly important. It has 4 homologous domains, like 4 repeating segments, each containing 6 transmembrane helices, designated S1 through S6, and an additional membrane reentrant pore, or P-loop. The actual Na+ selective transmembrane pore, the critical tunnel through which ions pass, resides in the very center of this nearly symmetrical structure formed by the 4 domains.
Right in the middle.
The voltage dependence of channel opening comes from what are called gating charges, located in the S4 transmembrane helices. These S4 segments are hydrophobic and positively charged. They move perpendicular to the membrane plane in response to changes in the transmembrane potential, initiating the conformational changes that open the channel.
Like little voltage sensors.
Exactly like voltage sensors. The pore itself and its selectivity filter are surrounded by the S5 and S6 transmembrane helices, along with that P-loop. Specific amino acid residues in these segments are critical for dictating which ions can pass through and how efficiently. After the channel opens, it rapidly inactivates within milliseconds. This happens due to the closure of an inactivation gate, a short intracellular protein loop connecting homologous domains 3 and 4, which folds over the intracellular mouth of the pore.
So it opens, then quickly slams shut again.
Almost. It inactivates. Now, for local anesthetics, the amino acid residues crucial for their binding are found in the S6 segments of domains, but third, and 4. Hydrophobic amino acid residues near the center of these S6 segments interact directly with the bound local anesthetics. This places the receptor site deep within the transmembrane pore of the Na+ channel.
Deep inside.
Yes. Schematically, you can visualize a voltage-gated Na+ channel as having a funnel-shaped extracellular vestibule that feeds ions into a narrow selectivity filter. This filter then opens onto a large, water-filled central cavity, which has an intracellular exit gate. Local anesthetics actually bind in this central cavity.
In the cavity itself.
Right. Recent high-resolution cryogenic electron microscopy cutting-edge imaging technology of channels like NAV 1.7 has revealed the functional components of the Na plus channel in atomic detail, confirming this precise local anesthetic binding position and demonstrating a remarkable conservation of structure across species.
So if I'm visualizing this correctly, it's not just sitting on the surface. It's getting deep into the heart of that sodium channel, physically blocking it. What's the most critical implication of that precise binding location for how the anesthetic works, especially when we talk about pain?
Precisely. The key insight is that by binding deep inside the pore, it physically blocks the passage of sodium ions from the inside, essentially acting as a stopper. And crucially, this access point from the inside is why the drug needs to get into the nerve cell first, which connects back to our earlier point about its uncharged form crossing the membrane.
Right.
This leads us to a concept of immense clinical relevance: frequency and voltage dependence, which is why we get selective pain blockade.
Okay, break that down. Frequency and voltage dependent.
Okay, the Na plus channel exists in multiple functional states: resting closed, intermediate closed, open, and inactivated. What's crucial here is that the conformation of the local anesthetic receptor site is significantly changed in the inactivated state.
The just shut state.
Kind of. The inactivated state. And this change dramatically increases its binding affinity for local anesthetics.
So it likes binding to the inactivated channels more.
Much more. This means the degree of block produced by a given local anesthetic concentration truly depends on how active the nerve has been and its resting membrane potential. A resting nerve is much less sensitive to a local anesthetic than one that is repetitively stimulated.
So active nerves get blocked more easily.
Exactly. Higher frequency of stimulation and more positive membrane potential actually cause a greater degree of anesthetic block. These frequency and voltage-dependent effects occur because the charged form of the local anesthetic molecule primarily gains access to its binding site when the Naples channel is open.
When the gate is open.
Right. And once it's in, the local anesthetic binds more tightly to and stabilizes the inactivated state of the Naples channel.
So it gets in when it's open and keeps it shut, basically.
It stabilizes the inactivated state, preventing it from reopening readily. This is a crucial concept. It means the rapidly fired action potentials, such as those signaling intense pain after a wound or during a surgical incision, are preferentially blocked.
Ah, because those nerves are firing like crazy.
Precisely. They're like the high-priority, noisy signals we get to shut down first. In contrast, more slowly fired action potentials that communicate other, less urgent sensory information, like light touch or temperature perception, are less affected.
Okay.
This mechanism significantly contributes to the selectivity of local anesthetic drug action. They target the problematic pain signals more effectively. The frequency dependence critically relies on the dissociation rate from the receptor site, how quickly the drug lets go. Rapidly dissociating drugs require a high frequency of stimulation for drug binding to exceed dissociation between action potentials. Interestingly, smaller and more hydrophobic drugs actually dissociate more rapidly, so they require a higher stimulation frequency to achieve that profound frequency-dependent block.
That's fascinating. It's like the pain signals are screaming louder, so the anesthetic hears them first and silences them. That makes perfect sense clinically. Now, on a slightly different but related note, when you get numb, sensation doesn't disappear all at once. There's an order. Pain goes first, then temperature, then touch, and finally, motor function. Why that specific sequence? Is it just about nerve fiber size? Like small nerves get blocked first?
You're right that differential sensitivity of nerve fibers is a classic clinical observation. For most patients, that exact sequence occurs. Autonomic fibers, small unmyelinated C fibers, which are primarily responsible for pain.
Pain fibers.
Yes, and small myelinated A fibers, which mediate pain and temperature, are generally blocked before larger myelinated AAA of fibers, which handle postural information, touch, pressure, and motor function. Now, while sensitivity does generally increase with decreasing fiber size, consistent with a high sensitivity for pain sensation mediated by those smaller fibers.
Not always that simple.
Exactly. Direct measurements of isolated nerve fibers haven't always shown a clear, simple correlation of concentration dependence with fiber diameter under steady-state conditions. So, you've hit on an important question. If it's not just fiber size, what else is at play?
Okay, what else?
Several factors contribute to this observed specificity. First, the spacing of nodes of Ranvier. These are gaps in the myelin sheath along myelinated nerves where action potentials are regenerated.
Right, the gaps.
That spacing increases with nerve fiber size. Smaller fibers have more closely spaced nodes. Since a fixed number of nodes must be blocked to prevent conduction, small fibers may be blocked more rapidly in intact nerves because the local anesthetic reaches a critical length of nerve more quickly.
Ah, like it covers more ground faster on the smaller ones.
In a sense, yeah. Second, differences in tissue barriers and the anatomical location of smaller C and A fibers within nerve bundles may influence the rate at which local anesthetics can access and act on them. Maybe they're just easier to reach. While different combinations of Na plus channel subtypes are expressed in various nerve fibers, our sources note that all these Na plus channels actually have similar affinity for block by local anesthetics, suggesting that the specific subtype isn't the primary driver of this differential sensitivity.
So it's more about the physical arrangement and accessibility, not just the size or the channel type itself. That makes sense. Speaking of getting the drug into the nerve, we talked about its uncharged form being important for crossing the membrane. But local anesthetics are weak bases and often delivered in acidic solutions. How does pH influence this entire process of getting into the cell versus getting to work?
The influence of pH is absolutely critical for that two-step process. You're right, local anesthetics are weak bases, meaning they can accept a proton. Their typical pKa values range from 8 to 9. They're generally marketed as water-soluble hydrochloride salts, which are mildly acidic. This acidity actually helps enhance the stability of ester-linked local anesthetics and any co-administered vasoconstrictors like epinephrine.
Okay, stability helps.
Upon administration, the solution's pH rapidly equilibrates with the extracellular fluids of your body, which are closer to neutral. Here's the key interplay. It is the unprotonated or uncharged species of the local anesthetic that is necessary for diffusion across the lipid-rich cellular membranes.
The neutral form gets through the fatty membrane.
Exactly. Think of it like a key fitting into the membrane's lock. It needs to be electrically neutral to pass through that fatty layer. However, once inside the cell, where the pH is typically closer to neutral, it is primarily the cationic, or charged and protonated species that interacts preferentially and with higher affinity with the sodium channels to exert its blocking action.
So it picks up a charge inside and then blocks the channel.
Precisely. This was elegantly demonstrated in experiments where conduction could be blocked or unblocked simply by adjusting the pH of the bathing medium and by showing that charged quaternary amines only worked when perfused intracellularly. So it's a two-step process. The uncharged form for crossing the barrier and the charged form for binding to the receptor. While the cationic form is primary, it's worth noting that the unprotonated molecular forms do also possess some anesthetic activity.
It's a clever biological workaround, getting in one form and acting in another. And to give these drugs staying power, keep them where they need to be, we often add something else to the solution, right? Like epinephrine. What's the role of these vasoconstrictors in prolonging the numbing effect?
Yes, the prolongation of action by vasoconstrictors is a vital strategy in clinical practice. The duration of action of a local anesthetic is directly proportional to the time it remains in contact with the nerve.
Makes sense. Keep it there longer, it works longer.
Exactly. The longer it stays localized, the longer the numbness lasts. Cocaine, uniquely, naturally inhibits neuronal membrane transporters for catecholamines, like norepinephrine. This potentiates norepinephrine's effect on alpha-adrenergic receptors in the vasculature, leading to vasoconstriction and reduced cocaine absorption. It essentially creates its own localized retention system.
Huh. Cocaine does that itself.
Yes. In broader clinical practice, a vasoconstrictor, most commonly epinephrine, is often added to local anesthetic solutions. This additive serves a dual benefit. First, by decreasing the rate of absorption from the site of injection, it localizes the anesthetic at the desired nerve, keeping it right where it needs to work.
Keeps it concentrated.
Right. Second, it allows the drug's elimination from the body to keep pace with its entry into the systemic circulation, thereby significantly reducing the drug's systemic toxicity.
That sounds like a win-win longer effect and reduced toxicity. But there must be a trade-off for situations where you wouldn't use a vasoconstrictor, right? You can't just add it everywhere.
That's a critical point to consider. You're absolutely right. There are important caveats. The vasoconstrictor itself can be absorbed systemically, sometimes sufficiently to cause unwanted reactions like increased heart rate or anxiety. Moreover, sympathomimetic amines, like epinephrine, increased tissue oxygen consumption. When combined with vasoconstriction, this can lead to localized hypoxia and tissue damage, potentially causing delayed wound healing, edema, or even in rare cases, necrosis.
Tissue damage. Okay, that's serious.
It is. Therefore, vasoconstrictors are meticulously avoided in local anesthetic preparations for anatomical regions with limited collateral circulation. Think fingers, toes, ears, the nose, and the penis. These areas rely on end arteries and are particularly susceptible to the risk of gangrene if blood flow is too restricted.
Definitely don't want that.
No. They are also generally avoided in intracutaneous injections, like right under the skin surface. And of course, their use should be avoided in patients for whom adrenergic stimulation, say from absorbed epinephrine, is undesirable. Perhaps those with certain cardiovascular conditions where increased heart rate or blood pressure could be harmful.
So careful patient selection and knowing your anatomy is key there. Now let's talk about when things go wrong systemically. If too much of these powerful drugs gets into the general circulation, what happens? What are the undesired effects we need to be aware of beyond the local numbing? This sounds like a critical balance act, given their wide-ranging effects.
It is indeed a critical balance, because since local anesthetics interfere with impulse conduction beyond just the target nerve, they can affect virtually any organ system where electrical signals are critical. The danger of adverse reactions is directly proportional to the concentration of the local anesthetic achieved in the systemic circulation. In general, for local anesthetics with chiral centers, meaning they have a mirror image form, the S enantiomer is generally less toxic than the R enantiomer. That's an interesting molecular detail relevant to safety, seen with drugs like bupivacaine and ropivacaine.
Okay.
Broadly, they can interfere with the function of the central nervous system, CNS, autonomic ganglia, neuromuscular junctions, and all forms of muscle. Let's start with the CNS effects. Following systemic absorption, local anesthetics may cause a biphasic response. Initially, they can cause CNS stimulation, producing restlessness and tremor that can progress to generalized clonic convulsions.
Convulsions. Wait, so it stimulates the brain by actually depressing something? That feels counterintuitive. Can you break that down just a bit more?
Yeah, it does seem backward, doesn't it?
Yeah.
It's a classic disinhibition effect. Think of it like this. Your brain has excitatory signals and inhibitory signals working in balance.
Like gas and brakes.
Exactly. Local anesthetics, initially at lower toxic concentrations, tend to knock out the brakes, the inhibitory neurons, more easily. Without those inhibitory brakes, the excitatory pathways run wild, leading to that initial restlessness, twitching, or even convulsions.
Ah, okay. Taking the brakes off first.
Right. This excitatory phase is then followed by generalized CNS depression as concentrations rise further, and in severe cases, death is typically caused by respiratory failure because the respiratory centers in the brainstem get depressed.
A dangerous progression.
Very. Interestingly, rapid systemic administration like an accidental large intravenous injection might produce death with no or only transient sign of CNS stimulation if the drug concentration rises so quickly that all neurons, inhibitory and excitatory, are depressed almost simultaneously. In terms of management for severe CNS intoxication, airway control, ventilatory support, and circulatory support are absolutely essential in the late stage. For preventing and arresting convulsions, intravenously administered benzodiazepines like diazepam or midazolam are the drugs of choice.
Benzos, okay.
Propofol or rapidly acting barbiturates are less preferred because they are more likely to cause cardiovascular depression, which is often already a major concern in these situations. On a more common scale, drowsiness is a frequent complaint, even at lower systemic levels. Lidocaine specifically can cause dysphoria, a feeling of unease, or surprisingly euphoria, along with muscle twitching. It can even lead to a loss of consciousness that is preceded only by sedation, sometimes skipping the obvious excitatory phase. Cocaine, as we discussed, has a particularly prominent effect on mood and behavior, primarily due to its inhibition of dopamine uptake in the brain, which is a key contributor to its abuse potential.
Okay, so CNS effects are significant. What about the heart and blood vessels, the cardiovascular system?
Moving to the cardiovascular system, following the systemic absorption, local anesthetics primarily act on the myocardium, the heart muscle itself. They cause decreases in electrical excitability, meaning the heart is less responsive to electrical signals, a decreased conduction rate, so electrical signals travel slower through the heart, and a reduced force of contraction, making the heart pump less effectively.
So slower, weaker heart function.
Essentially, yes. Most local anesthetics also cause arteriolar dilation, meaning peripheral blood vessels widen, which can lower blood pressure. Untoward cardiovascular effects usually only appear after high systemic concentrations are attained, and CNS symptoms are already quite evident. It's often a later sign than the CNS effects.
Generally follows the CNS signs.
Generally. However, on rare occasions, lower doses of some local anesthetics can cause cardiovascular collapse and death, possibly due to a direct action on the heart's pacemaker cells or the sudden onset of ventricular fibrillation, a life-threatening chaotic heart rhythm.
That's a sobering thought. So it's generally a cascade from CNS effects to cardiac, but sometimes it can be primary cardiac. Is there one local anesthetic that stands out as having particularly cardiovascular concerns?
Absolutely, and this is a critical distinction we need to make. Bupivacaine's unique cardiotoxicity.
Bupivacaine. Okay.
Ventricular tachycardia and fibrillation, while uncommon with most local anesthetics, are a specific and significant concern with bupivacaine. The mechanism is quite specific. While both lidocaine and bupivacaine rapidly block cardiac nauplius channels during systole, the heart's contraction phase, bupivacaine dissociates much more slowly than lidocaine during diastole, the heart's relaxation phase.
It hangs on longer inside the heart cells.
Exactly. It lets go much more slowly. This means that a significant fraction of nauplius channels remains blocked with bupivacaine at physiological heart rates, leading to a cumulative and more profound block than predicted simply by its anesthetic potency. It builds up block upon block.
Accumulates block.
Wow. Furthermore, at least some of bupivacaine's cardiac toxicity may be centrally mediated, as direct injection into the medulla of the brain can produce malignant ventricular arrhythmias. Bupivacaine-induced cardiac toxicity is notoriously difficult to treat, and its severity is worsened by coexisting acidosis, low blood pH, hypercarbia, high CO2, and hypoxemia, low oxygen. This emphasizes the critical importance of prompt airway control and good ventilation during resuscitation from a bupivacaine overdose.
Got it. Bupivacaine needs extra caution.
Definitely. Untoward cardiovascular effects can also result from inadvertent intravascular administration, especially if epinephrine is also present in the solution. Interestingly, some local anesthetics like lidocaine and procainamide are also used clinically as antiarrhythmic drugs because of these very effects on cardiac ion channels, highlighting a therapeutic duality. A drug side effect at high doses becomes its therapeutic target at lower controlled doses.
Fascinating. What about other muscles, like smooth muscle in the gut or airways?
Yes, they affect smooth muscle too. Local anesthetics depress contractions in the intact bowel and isolated intestine preparations. They also relax vascular and bronchial smooth muscle, though interestingly, low concentrations can initially cause contraction before relaxation sets in. When spinal and epidural anesthesia is administered, it can cause sympathetic nervous system paralysis, which paradoxically results in increased tone of gastrointestinal musculature due to unopposed parasympathetic activity.
So blocking nerves increases gut tone.
In that specific context, yes, by blocking the inhibitory sympathetic nerves. They may increase resting tone and decrease contractions of isolated human uterine muscle. But direct depression of uterine contractions during labor is seldom observed in clinical practice. At high concentrations, local anesthetics can also affect transmission at the neuromuscular junction, where nerves connect to skeletal muscles, and at autonomic ganglia, which are nerve relay stations. This effect is due to blockade of nicotinic acetylcholine receptors, leading to a block of skeletal muscle response to nerve volleys and acetylcholine, similar to effects seen at autonomic ganglia, basically interfering with the signal transmission there too.
Okay. And what about allergic reactions? You hear about people being allergic to Novocaine or similar. How common is that?
Finally, yes, hypersensitivity or allergic reactions. Rare individuals can be hypersensitive to local anesthetics, manifesting as allergic dermatitis, a skin rash, or sometimes a typical asthmatic attack. It is absolutely crucial to distinguish true allergic reactions from toxic side effects or from the effects of co-administered vasoconstrictors, as the management differs significantly. A racing heart from epinephrine isn't an allergy, for example.
Right. Important difference.
Hypersensitivity occurs more frequently with ester-type local anesthetics, like procaine or tetracaine. And it often extends to chemically related compounds. For example, individuals sensitive to procaine may react to tetracaine due to a common metabolite, paraminobenzoic acid, or PABA.
So cross-reactivity within the ester group.
Correct. Allergic responses to amide-bide agents, like lidocaine or bupivacaine, are uncommon. Very rare, actually. However, solutions of amided local anesthetics may contain preservatives like methylparaben, which can themselves provoke an allergic reaction in susceptible individuals.
So the preservative could be the culprit, not the anesthetic itself.
Exactly. Also, local anesthetic preparations containing a vasoconstrictor may elicit allergic responses due to the sulfite added as an antioxidant for the catecholamine, like epinephrine. Sulfite allergies exist too.
Lots of potential confounders there. Good to distinguish. So the body has to get rid of these drugs eventually. How does it process them? How are they metabolized? And how does that relate to safety and toxicity, especially if, say, someone's liver isn't working well?
Right. The metabolic fate of local anesthetics is of great practical importance because toxicity often results from a delicate imbalance between the rates of absorption into the body and their elimination from it. If elimination slows down, levels can build up. Let's look at the metabolism pathways, differentiating between the ester and amide bite types we discussed earlier.
Ester versus amide again.
Yes, it's a key difference. Ester-type local anesthetics, like tetracaine or procaine, are primarily hydrolyzed and inactivated by enzymes in your blood plasma, called plasma esterases, likely plasma cholinesterase. The liver also participates in this hydrolysis to some extent. A key point here is that spinal fluid contains little or no esterase. This means anesthesia, produced by intrathecal or spinal injection of an ester anesthetic, will persist until the drug is absorbed into the systemic circulation, where those plasma esterases can finally break it down.
So a spinal block with an ester lasts until it gets washed out into the blood.
Essentially, yes. Amide-linked local anesthetics, on the other hand, are generally degraded by enzymes in the liver, particularly the cytochrome P450, or CYP, enzymes. The initial reactions typically involve end-alkylation, where part of the molecule is clipped off, followed by subsequent hydrolysis. Prelocaine is an interesting exception among amides, where the initial step is hydrolytic, forming O-toluidine metabolites.
Okay.
What's noteworthy here is that this specific metabolite, O-toluidine, can cause methemoglobinemia.
Methemoglobinemia. That affects oxygen carrying.
Exactly. It's a condition where hemoglobin in your red blood cells cannot effectively carry oxygen, leading to a bluish discoloration, especially of the lips and nail beds, and potential organ damage if severe. This effect is dose-dependent and, if significant, can be treated with intravenous methylene blue.
Okay, a specific risk with prelocaine.
Yes. And given that amide-linked local anesthetics rely heavily on hepatic degradation, caution is certainly required when using them in patients with severe liver disease, as their metabolism will be impaired, leading to higher blood levels and an increased risk of systemic toxicity.
Makes sense. Liver disease means slower breakdown for amides.
Exactly. Several factors beyond just the metabolic pathway influence systemic toxicity. The absorption rate, as we've discussed, is a major one. Vasoconstrictors reduce absorption, keeping systemic levels lower. The degradation rate of the local anesthetic itself varies greatly among agents and is a major factor in determining an agent's safety profile. Faster degradation generally means lower risk. Protein binding is another critical factor. Toxicity is related to the concentration of free or unbound drug in the blood.
Only the free drug is active and potentially toxic.
Correct. When the anesthetic binds to proteins in the serum, particularly plasma proteins like albumin, especially alpha-1 acid glycoprotein, and also to tissues, it reduces the amount of free drug available to cause effects, thereby reducing toxicity. Amide-linked local anesthetics bind extensively, from 55% up to 95%, to plasma proteins, especially to alpha-1 acid glycoprotein.
Wow, that's a lot of binding.
It is, and many factors can actually increase the level of this glycoprotein. For example, conditions like cancer, surgery, trauma, myocardial infarction, smoking, and uremia.
So in those conditions, there's more binding protein.
Yes, which can mean less free drug, potentially altering the dose response. Conversely, some factors, like oral contraceptives, can decrease its level, potentially increasing free drug concentration. These changes in protein levels can significantly alter the amount of anesthetic delivered to the liver from metabolism and consequently influence systemic toxicity.
So the patient's overall health state really matters for protein binding.
Absolutely. Age-related changes in protein binding also occur. Neonates, for instance, are relatively deficient in plasma proteins that bind local anesthetics and are therefore more susceptible to toxicity.
More vulnerable.
Yes.
Yes.
It's important to note that plasma proteins are not the sole determinant of local anesthetic availability. Uptake by the lung also plays an important role in the distribution of amide-linked local anesthetics after 5E administration. Finally, reduced cardiac output also slows the delivery of amide compounds to the liver, which in turn reduces their metabolism and prolongs their plasma half-lives, increasing the risk of toxicity in patients with heart failure, for example.
So it's a complex interplay of how quickly the body takes it in, how quickly it breaks it down, and even how it binds to proteins circulating in the blood or in tissues. Given all these variables and the potential for serious toxicity, what happens if things go wrong? Is there a breakthrough in managing severe local anesthetic toxicity that we should know about, like an antidote?
That's an excellent question. As reversing the severe effects of local anesthetic systemic toxicity, or LAST, is a significant clinical challenge that, until relatively recently, had limited specific antidotes beyond supportive care. What's truly exciting, really a game changer here, is the developing and now quite established approach of intravenous lipid emulsion therapy. Intralipid is a common brand name.
Lipid emulsion, like fat.
Essentially, yes.
Huh?
An intravenous infusion of a fat emulsion, similar to what's used for intravenous nutrition.
How does fat help with anesthetic toxicity?
Well, the exact mechanism is still under intense study and debate.
Yep.
But the leading theory is the lipid sink effect. The idea is that the lipids provide a greatly expanded fatty compartment within the blood plasma. Since local anesthetics are lipophilic fat-loving, they partition into these lipid micelles, effectively pulling the drug out of the aqueous phase of the blood and away from the target tissues like the heart and brain.
So the fat literally soaks up the anesthetic.
That's the lipid sink idea, yes. It reduces the free concentration of the drug. There might be other mechanisms too, perhaps related to improving myocardial energy metabolism or direct effects on ion channels, but the sink effect is widely accepted. Regardless of the precise mechanism, it offers a vital and often life-saving new tool for managing severe local anesthetic overdoses, especially for highly lipid-soluble agents like bupivacaine, where it's dramatically improved outcomes.
That's a crucial innovation for patient safety, a real breakthrough. Now that we've really explored the molecules, their mechanisms, how the body handles them, and even how to treat toxicity, let's meet some of the individual players in this field, from the old guard to the modern workhorses, and even some unexpected agents. Who are the key local anesthetics and related compounds we should know, and what sets them apart clinically?
Understanding the specific properties of individual agents is absolutely key to their safe and effective clinical application. Let's start with the historic pioneer, cocaine.
Back to cocaine.
Yes. Chemically, it's an ester of benzoic acid and methylecanoin. Its clinically desired actions are, as we know, nerve impulse blockade, and uniquely among local anesthetics, local vasoconstriction, secondary to its inhibition of the norepinephrine transporter, NET.
Right, the built-in vasoconstriction.
Exactly. This inhibition leads to a localized increase in norepinephrine, constricting blood vessels. Its high systemic toxicity stems from reduced catecholamine uptake in both the central and peripheral nervous systems, prolonging neurotransmitter activity. Its euphoric properties are primarily due to its inhibition of dopamine uptake in the CNS. Unlike other local anesthetics, cocaine does block norepinephrine uptake and produces characteristic sensitization to catecholamines, widespread vasoconstriction, and pupil dilation, mydriasis.
So it's really quite different pharmacologically from the others.
Very different in those respects. Today, cocaine is primarily used clinically for topical anesthesia of the upper respiratory tract, nose, throat. Here, its combined vasoconstrictor and local anesthetic properties provide both anesthesia and beneficial shrinking of the mucosa, which is excellent for surgical visualization and decreasing bleeding during procedures in those areas.
So still used, but very specifically.
Very specifically, yes. Available typically as 1%, 4%, or 10% solutions for topical application, with the lower concentrations preferred to reduce toxicity risk. It's a Schedule II controlled substance due to its high abuse potential.
Okay. Now, what about the real modern workhorse, lidocaine?
Right, lidocaine. The prototypical amide. It produces faster, more intense, longer-lasting, and more extensive anesthesia than procaine at equal concentrations. It's a key alternative for individuals sensitive to those ester-type local anesthetics.
So very versatile.
Incredibly versatile. A transdermal patch formulation, lidoderm, is used for relief of pain associated with postherpetic neuralgia shingles pain. It's also found in eutectic mixtures. Combined with prelocaine, EMLA cream, 2.5% each, applied under an occlusive dressing for anesthesia prior to things like venipuncture or skin graft harvesting. There are also topical combinations like lidocaine with tetracaine pliglis used for superficial dermatological procedures.
Lots of different ways to deliver it.
Yes, its ADME profile shows rapid absorption after parenteral injection, but also decent absorption after GI and respiratory administration. Epinephrine is often added to decrease absorption rate from injection sites, thus reducing toxicity probability and prolonging its action. It's formulated for topical, ophthalmic, mucosal, and transdermal use, as well as injection. Metabolism-wise, it's delicollated in the liver by CYP enzymes, primarily CYP1A2 and CYP3A4, to metabolites like monoethylglycine MBX and glycine-zeolidide PMX, both of which retain some local anesthetic activity and can contribute to side effects if they accumulate, like in severe liver disease.
So the metabolites can be active too.
They can. Side effects with increasing doses include drowsiness, tinnitus, ringing in ears, dysgeusia, taste disturbance, dizziness, and muscle twitching. Higher doses can lead to seizures, coma, respiratory depression, and arrest. Importantly, clinically significant cardiovascular depression usually occurs only at serum lidocaine levels that already produce marked CNS effects.
CNS effects usually come first with lidocaine.
Usually, yes.
Yeah.
Lidocaine has a wide range of uses as an intermediate duration local anesthetic and is also famously used intravenously as an antiarrhythmic drug, particularly for ventricular arrhythmias.
Okay, lidocaine. Versatile, allied, intermediate duration. What about bupivacaine? You mentioned its cardiotoxicity earlier.
Yes. Bupivacaine, another widely used amide but potent and long duration and crucially carrying that higher risk of cardiotoxicity. Its structure is similar to lidocaine, but with a specific butyl group attached to the piperidine ring nitrogen. It's a potent agent capable of producing prolonged anesthesia, sometimes lasting many hours. Its long duration and tendency to provide more sensory than motor block, meaning pain relief with less muscle weakness, have made it extremely popular for prolonged analgesia during labor or the postoperative period.
Good for walking epidurals, maybe.
Exactly. Allows for mobility while controlling pain. It can provide several days of analgesia when administered via indwelling catheters and continuous infusions, for example, after major surgery. A liposomal bupivacaine preparation, Exparel, is also FDA approved for single-dose infiltration, intended for prolonged release, though its clinical superiority over conventional bupivacaine infusions hasn't been consistently demonstrated across all studies. ADME. It's absorbed more slowly than lidocaine from tissue sites, so plasma levels rise more slowly after nerve blocks or epidural injection. Its levels also fall more slowly after stopping continuous infusions because it's cleared more slowly. It is primarily metabolized in the liver by CYP3A4. Toxicity. As we discussed, bupivacaine is significantly more cardiotoxic than equi-effective doses of lidocaine. This manifests as severe ventricular arrhythmias and myocardial depression after inadvertent intravascular administration.
And that's due to the slow dissociation from heart sodium channels.
Precisely. Bupivacaine dissociates much more slowly from cardiac NAB plus channels during diastole, leading to that cumulative channel blockade at physiological heart rates. And remember, this bupivacaine-induced cardiac toxicity is difficult to treat, and its severity is enhanced by coexisting acidosis, hypercarbia, and hypoxemia. Lipid emulsion therapy is key here.
Got it.
Despite this cardiac concern, which requires meticulous injection technique to avoid intravascular placement, it remains incredibly useful clinically for a wide range of procedures where a long duration of action is needed, like major nerve blocks and epidural or spinal anesthesia for longer surgeries.
That's a clear distinction between the two main amides. Are there any other notable injectable local anesthetics we should quickly highlight for their unique characteristics or uses?
Absolutely. There are several others worth mentioning briefly. Articaine, primarily used in dentistry. It's unique in that while it's classified as an amide, it also contains an ester group in its structure. This ester is rapidly hydrolyzed by plasma esterases, leading to a very rapid onset, 1 to 6 minutes, and a relatively short duration of action, 1 hour. This rapid breakdown also potentially reduces systemic toxicity risk.
Interesting hybrid structure.
Yes. Chloroprocaine. This is an ester, a chlorinated derivative of procaine. Its major assets are very rapid onset and extremely short duration due to rapid metabolism by plasma cholinesterase. Plasma half-life is only about 25 seconds. This makes it suitable for short procedures or where rapid recovery is desired. There were past concerns regarding prolonged sensory motor block after epidural subarachnoid administration, possibly linked to low pH and the sodium metabisulfite preservative in older formulations. Newer formulations with EDTA seem safer, but aren't generally recommended intrathecally. It has also been linked to muscular back pain after epidural use, possibly due to calcium binding by EDTA.
Wrap it on, wrap it off.
Exactly. Bupivacaine, an intermediate-acting aminoamide, pharmacologically quite similar to lidocaine. It's noted to be slightly more toxic to neonates, possibly due to ion trapping from lower neonatal pH, so it's generally not used in obstetrical anesthesia. It might have a slightly higher therapeutic index, wider safety margin, in adults compared to lidocaine. Onset is similar to lidocaine, duration slightly longer, 20% when used without a vasoconstrictor. Importantly, it's not effective as a topical anesthetic. Prilocaine, another intermediate-acting aminoide similar to lidocaine. It causes little vasodilation, so it can sometimes be used effectively without adding a vasoconstrictor. It has an increased volume of distribution, which might reduce its CNS toxicity relative to lidocaine, making it suitable for intravenous regional blocks, beer blocks. However, its unique propensity to cause methemoglobinemia due to that otiluti metabolite limits its use largely to dentistry in many places. Remember, this is treatable with methylene blue if needed.
The methemoglobinemia risk again.
Yes. Ropivacaine, The sumated was specifically developed as a potentially safer alternative due to bupivacaine's cardiac toxicity concerns. It's an aminoethylamide marketed as the pure S enantiomer, which was chosen for its lower toxicity compared to the R isomer or the racemic mixture. It's slightly less potent than bupivacaine, but suitable for epidural and regional anesthesia with a similar long duration of action. It appears to be even more motor-sparing than bupivacaine, meaning it causes less muscle weakness for a given level of sensory block.
Designed for better safety profile?
That was the goal, yes, particularly regarding cardiotoxicity. Procaine. As mentioned, the original synthetic prototype, it's no longer marketed as a single entity for injection in the U.S., though it's still an ingredient in some long-acting intramuscular penicillin formulations, procaine, penicillin G. Tetracaine, a long-acting amino ester, significantly more potent and has a longer duration than procaine. It may have increased systemic toxicity compared to other esters due to slower metabolism. It's widely used in spinal anesthesia when a long duration is required. It's also found in some topical preparations. Its use for peripheral nerve blocks has decreased and since bupivacaine's introduction, partly due to its slower onset and the potential for toxicity with a large doses sometimes needed for those blocks.
Okay, that covers the main injectables. What about agents used mostly on the surface, like skin and mucous membranes?
Right, there are several agents used primarily topically. Some are effective on mucous membranes or skin, but might be too irritating for sensitive areas like the eye. They're often used for symptomatic relief of itching, pruritus, from rashes or dermatosis, sometimes combined with glucocorticoids or antihistamines. Dibucaine, a quinoline derivative. It was removed from the U.S. injectable market due to toxicity, but remains popular outside the U.S. as a spinal anesthetic. It is available OTC as an ointment for cutaneous use, for example, for hemorrhoids. Diclonine has a rapid onset and short duration. It's the active ingredient in some OTC sore throat lozenges, like Sucrets in the past, and cold sore patches. It's readily absorbed through skin and mucous membranes. Bramixine. This is a surface anesthetic that is not a benzoate ester like procaine or tetracaine. Its distinct chemical structure may minimize cross-sensitivity reactions in patients allergic to other ester or even mild local anesthetics, making it a useful alternative. It provides satisfactory surface anesthesia and is generally well tolerated on skin and mucous membranes, but it's too irritating for the eye or nose. It's marketed in various topical formulations like creams, lotions, and sprays.
Pramoxine sounds like a good option for allergies.
It can be. Then there's a category of anesthetics with very low aqueous solubility, like benzocaine.
Benzocaine like an Orahel.
Exactly. These compounds are absorbed very slowly from the application site, meaning they generally don't cause classical systemic toxicity unless used improperly or over vast areas of damaged skin. Because they stay put, they can be applied directly to wounds and ulcerated surfaces, remaining localized for sustained anesthetic action. Chemically, they are typically esters of para-aminobenzoic acid, but lack the terminal amino group found in drugs like procaine. Benzocaine, ethyl aminobenzoate, is the most important member, found in many OTC topical preparations for teething pain, sore throats, sunburns, etc. Like prilocaine, however, benzocaine can cause methemoglobinemia, especially with sprays used to the throat or high concentrations, so careful dosing and awareness are needed. The FDA has issued warnings about this risk, particularly in young children.
Another methemoglobinemia risk there. Good to know. What about specifically for the eye? You mentioned some are too irritating.
Right. For ophthalmic use, anesthesia of the cornea and conjunctiva is achieved by topical application, but most general local anesthetics are too irritating. Proparacaine and tetracaine are the most frequently used agents for eye procedures like tonometry, measuring eye pressure, or removing foreign bodies. Proparacaine is generally considered less irritating upon installation and has little antigenic similarity to other benzoate local anesthetics, making it useful for potentially sensitive individuals. Administration is usually single drops instilled until anesthesia is satisfactory. The duration depends on the tissue vascularity longest in the normal cornea, shortest in an inflamed, blood-rich conjunctiva. A critical caution. Long-term topical ophthalmic use of these anesthetics can retard corneal healing, cause pitting or slowing of the corneal epithelium, and predispose the eye to injury because the protective blink, reflex, and pain sensation are lost. They should never be prescribed for self-administration by patients.
Definitely only for in-office use by professionals.
Absolutely.
Now, switching gears slightly, you mentioned cocaine inhibits norepinephrine uptake. Are there other natural substances that affect these nerve channels? Maybe not used as anesthetics, but important for understanding them?
Yes. There are some incredibly potent biological toxins that, while certainly not used clinically as anesthetics due to their lethality, have been absolutely crucial research tools for scientists trying to understand exactly how sodium channels work.
Toxins, like from animals.
Exactly. The two most famous are tetrodotoxin, TTX, and saxitoxin, STX.
Tetrodotoxin, that's the pufferfish toxin, right? Fugu?
Precisely. TTX is found in the gonads and visceral tissues of pufferfish, but also in the skin of some newts and even certain tropical frogs. Saxitoxin, on the other hand, is produced by marine dinoflagellates, the microorganisms responsible for red tides.
Red tides, okay.
Shellfish, like clams and mussels, filter feed on these dinoflagellates and can accumulate saxitoxin. If humans eat these contaminated shellfish, it causes paralytic shellfish poisoning.
Paralytic, so they block nerves too.
Yes, very effectively. What's truly fascinating here is that these two biological toxins, though chemically quite distinct from each other and from local anesthetics, share a similar and incredibly potent mechanism. They specifically block the outer mouth of the voltage-gated nave plus channel pore.
The outside, whereas local anesthetics block from the inside.
Exactly. They act at a distinct receptor site, right at the external opening of the pore. They bind with extremely high affinity, even at nanomolar concentrations, that's billionths of a mole per liter, effectively plugging the channel from the outside and preventing sodium ions from entering. This completely stops action potential generation.
Wow, extremely potent.
Exceedingly potent. The minimal lethal dose in mice is tiny, around 8 micrograms per kilogram. They cause fatal poisoning in humans, primarily due to paralysis of respiratory muscles. You simply can't breathe. Hypotension from blockade of vasomotor nerves and direct relaxation of vascular smooth muscle is also characteristic, especially of TTX poisoning.
Scary stuff. How is poisoning treated?
There's no specific antidote. Treatment requires immediate and prolonged respiratory support, often mechanical ventilation, until the toxin is clear from the body. Early gastric lavage might help remove unabsorbed toxin. Pressor support might be needed for low blood pressure. The prognosis is generally good if the patient survives the initial 24 hours.
So supportive care is key.
Absolutely. It's also interesting that not all NAM plus channels are equally sensitive. Some subtypes found in cardiac myocytes and certain sensory neurons, dorsal root ganglia neurons, are resistant to TTX block. And a TTX-resistant channel is also expressed in denervated skeletal muscle. These toxins, because of their high specificity and potency, have been invaluable molecular probes for isolating, purifying, and studying the structure and function of sodium channels.
Incredible tools, despite being dangerous poisons. Now that we've explored the molecules, their mechanisms, met the specific players, and even touched on toxins, how are these local anesthetics actually put to use in the clinic day-to-day? What are the different ways they're administered, and what are the specific considerations for each method to achieve that safe, effective numbness?
Right. Moving to clinical applications. Local anesthesia, defined as the loss of sensation in a specific body part without loss of consciousness, offers significant advantages over general anesthesia in many situations.
Like avoiding being put completely to sleep.
Exactly. Primarily, it avoids the extensive physiological perturbations associated with general anesthesia, like the need for complex airway management, mechanical ventilation, and the systemic effects of general anesthetic drugs. It also allows for beneficial modification of pain and stress responses, which can significantly improve patient recovery after surgery. However, as we've emphasized, proper choice of drug and dose and careful technique are paramount to avoid deleterious side effects, given the potent nature of these drugs. A general principle to understand first is that there's often a surprisingly poor relationship between the total dose of local anesthetic injected and the peak plasma levels achieved in adults.
So the same dose can lead to different blood levels. Why?
Because the absorption rate varies dramatically depending on the injection site. It's highest with highly vascular areas like interpleural or intercostal blocks between the ribs, and lowest with simple subcutaneous infiltration in less vascular tissue. So the recommended maximum doses you might see published serve only as general guidelines. Clinicians must adjust the dose based on the specific site, the patient's size and condition, and whether a vasoconstrictor is used.
Site matters a lot for absorption. Got it.
Definitely. Let's start with topical anesthesia. This involved the direct application of aqueous solutions or suspensions, often of the poorly soluble local anesthetics, to mucous membranes, like those lining the nose, mouth, throat, tracheobronchial tree, esophagus, or genitourinary tract, or sometimes to denuded skin, where the top layer is missing.
Sprays, gels, liquids.
Exactly. Common agents used topically include tetracaine, perhaps 2%, lidocaine, often 2% to 10%, and cocaine, 1% to 4%. Cocaine, as we noted, is unique for use in the nose, nasopharynx, mouth, throat, and ear because of its inherent vasoconstriction. This shrinks the mucous membranes, which decreases operative bleeding and improves surgical visualization, a big help for surgeons working in those areas.
The shrinking effect is key there.
Yes. Other local anesthetics can achieve comparable vasoconstriction if you add phenylephrine, around 0.005% to the solution. Interestingly, topically applied epinephrine doesn't have a significant local vasoconstrictor effect and doesn't really prolong duration on mucous membranes, likely due to poor penetration. Peak anesthetic effect usually occurs within 2 to 5 minutes for lidocaine or cocaine, maybe 308 minutes for tetracaine, and the numbness typically lasts 30-45 minutes, maybe up to 60 minutes for tetracaine. It's important to remember this anesthesia is entirely superficial. It does not extend significantly into submucosal structures or alleviate deeper pain like joint or subdermal pain.
Surface only.
Right, and a critical risk with topical anesthesia is potentially rapid systemic absorption from these highly vascular mucous membranes or from denuded skin. This poses a real systemic toxicity risk if large amounts or high concentrations are used over large areas. There have been reports of toxicity, for instance, even from treating severe diaper rash in infants with topical anesthetics. Absorption from the tracheobronchial tree, like during bronchoscopy, is particularly rapid, with resulting blood concentrations potentially approaching those seen after direct IV injection. So caution is needed.
Okay, need to be careful with topical application, especially on damaged skin or mucous membranes. What about those special creams like EMLA?
Yes, the eutectic mixtures. EMLA, lidocaine 2.5%, prelocaine 2.5%, and Pliaglis, lidocaine 7%, tetracaine 7%, are interesting formulations that sort of bridge the gap between purely topical and infiltration anesthesia.
How do they work?
The term eutectic means the mixture of the two solids has a melting point lower than either compound alone. In this case, the mixture exists as an oil at room temperature, even though the individual components are solids. This oily phase allows the anesthetic agents to penetrate intact skin much better than standard aqueous solutions.
So they can get through healthy skin?
Yes, to a degree. They are typically applied as a cream on intact skin under an occlusive dressing, like a clear plastic film, for about 30 to 60 minutes prior to a procedure. They provide effective anesthesia to a maximum depth of about 5 millimeters, useful for things like starting IVs, venipuncture, superficial skin biopsies, or harvesting thin skin grafts.
Useful for needle phobia.
Definitely. However, beware. The component local anesthetics will be absorbed systemically through the skin, especially with prolonged application or over large areas, potentially producing toxic effects. Guidelines for the maximum amount and area covered, especially in children, must be followed carefully. And crucially, these mixtures must not be used on mucous membranes or abraded skin because absorption will be much faster and less predictable, leading to a high risk of systemic toxicity. Intact skin only.
Got it. Intact skin. Now, standard injection techniques. What's infiltration?
Infiltration anesthesia is probably the most common technique. It involves injecting the local anesthetic solution directly into the tissue without specific regard for the exact course of the cutaneous nerves in that area. It can be very superficial, just numbing the skin, or involve deeper structures like subcutaneous tissue or muscle layers.
Just injecting it where you need the numbness.
Pretty much. The duration of infiltration anesthesia can be approximately doubled by adding epinephrine, typically 5 micrograms per ml, which is a 1.200,000 dilution, which also beneficially decreases the peak blood concentration to the local anesthetic by slowing its absorption.
The vasoconstrictor effect again.
Right. But remember those contraindications for epinephrine. Epinephrine-containing solutions are generally not injected into tissues supplied by end arteries, fingers, toes, ears, nose, penis, due to the concern for vasoconstriction leading to gangrene. Also avoided intracutaneously, right into the skin layer itself, which can cause tissue blanching and potential necrosis, and avoided if adrenergic stimulation is undesirable for the patient. Common agents and concentrations for infiltration are lidocaine, maybe 0.5% or 1%, and bupivacaine, often 0.125% or 0.25%. Maximum recommended doses without epinephrine are around 4.5 mg/kg for lidocaine and 2 mg/kg for bupivacaine in adults. With epinephrine, these amounts can typically be increased by about 1/3 because the absorption is slowed. There's also a special case called tumescent anesthesia involving very large volumes of dilute lidocaine and epinephrine infiltrated for procedures like liposuction. The advantage of infiltration is that it provides satisfactory anesthesia without significantly disrupting normal bodily functions. The main disadvantage is that it often requires relatively large amounts of drug to anesthetize even small areas, which increases the potential risk of systemic toxicity if used for major surgical procedures requiring large infiltrated areas.
Makes sense. More targeted approaches.
Yes, field block anesthesia is related to infiltration, but it involves subcutaneous injection in a pattern designed to anesthetize a region distal, further away, to the injection site by blocking the nerves as they enter the field. Examples include blocking nerves around the wrist for hand procedures, around an incision site on the scalp or abdominal wall, or around the ankle for foot surgery.
Creating a wall of numbness.
Exactly. Less drug can often be used to provide a greater area of anesthesia compared to just infiltrating the entire area directly. The key requirement for success, though, is a good knowledge of the relevant neuroanatomy to place the injections correctly. Drugs and doses are generally the same as for infiltration.
Okay, field block targets the edges. What about hitting the nerve directly?
That's nerve block anesthesia. This involves injecting the local anesthetic solution directly into, or more commonly, around individual peripheral nerves or nerve plexuses, networks of nerves. This produces much greater areas of anesthesia than topical, infiltration, or field block methods.
Bigger areas of numbness.
Yes, often entire limbs or large regions of the body. Nerve blocks frequently anesthetize somatic motor nerves as well as sensory nerves, providing skeletal muscle relaxation, which can be essential for some surgical procedures, like orthopedic surgery. Anatomical targets are diverse: the brachial plexus in the neck, shoulder for arm and shoulder surgery, intercostal nerves between the ribs for chest or upper abdominal wall procedures, cervical plexus for neck surgery, sciatic and/or femoral nerves in the leg for surgery, distal to the knee, or individual nerves at the wrist, ankle, or elbow for more localized procedures. Even sensory cranial nerves can be blocked.
Lots of specific targets. What determines how quickly a nerve block works?
The onset of sensory anesthesia after a nerve block depends on 4 major factors. 1. Proximity to the nerve. Closer is faster. Modern techniques often use ultrasound guidance or nerve stimulators to deposit the anesthetic as close as possible to the nerve. Importantly, the anesthetic is never intentionally injected directly into the nerve substance itself, as this is painful and can cause nerve damage. It's deposited around the nerve sheath. 2. Concentration and volume of drug. Higher concentration generally means a steeper diffusion gradient and faster onset. However, this is limited by the potential for systemic toxicity and direct neural toxicity from highly concentrated solutions. Volume helps spread the anesthetic along the nerve or plexus. 3. Degree of ionization of the drug. As we discussed with pH, the unionized form penetrates nerve membranes faster, so local anesthetics with lower pKa values, closer to physiological pH, tend to have a more rapid onset because a larger fraction of the drug is uncharged at neutral pH.
For example, lidocaine, pKa is 7.9, has a faster onset, maybe 3 to 5 minutes, compared to bupivacaine, pKa 8.1, which might take 15-20 minutes, partly because lidocaine has more uncharged base available at body pH. 4. Time. Simple diffusion takes time. The drug needs time to migrate from the injection site through tissues and nerve sheaths into the nerve fibers themselves.
So proximity, dose, chemistry, and time. Makes sense. What about duration?
The duration of a nerve block depends primarily on the specific local anesthetic's physical characteristics, especially its lipid solubility and protein binding, which keep it associated with the nerve tissue, and whether a vasoconstrictor like epinephrine is added.
More lipid-soluble and protein-bound means longer lasting.
Generally, yes. We can broadly categorize local anesthetics by their duration in nerve blocks. Short-acting, maybe 20-45 minutes without epinephrine, reasonable. Procaine, historical. Intermediate acting, maybe 60-120 minutes. Or lidocaine, bupivacaine. Long acting can be 400-450 minutes or even longer. Example, bupivacaine, ropivacaine, tetracaine. Epinephrine's role in prolonging duration is most pronounced with the intermediate acting agents like lidocaine, especially those that have significant intrinsic vasodilating properties, which lidocaine does. It can easily double the duration. Its effect on the inherently long-acting drugs like bupivacaine is less dramatic, but still present.
Okay. When you block a big nerve, like in the arm, do all the fibers get blocked at the same time?
Not necessarily. There's often a differential block within mixed nerves. When local anesthetic is deposited around a mixed peripheral nerve, containing motor, sensory, autonomic fibers of different sizes, it diffuses from the outer surface, the mantle, toward the core along a concentration gradient. Nerves located in the outer mantle are exposed to higher concentrations first and are blocked first. These often supply more proximal anatomical structures and might include larger motor fibers. With sufficient volume and concentration, the anesthetic diffuses inward to block even the central core fibers. However, if lesser amounts are used, only the mantle nerves or perhaps smaller, more sensitive fibers in the core might be blocked.
So outside in for onset, what about recovery?
Recovery tends to happen in the opposite direction, often core out. Removal of local anesthetics from the nerve occurs primarily via uptake into the blood vessels, which are often located more centrally within the nerve bundle. Therefore, blockade duration might actually be shorter for the centrally located nerves compared to the more peripheral mantle fibers, which are further from the washout circulation.
Interesting. Core gets blocked last, recovers first.
Generally speaking, yes. The choice of local anesthetic, its amount, and concentration for a nerve block are carefully determined by the specific target nerves and fiber types. Example, do you need motor block or just sensory? The required duration of anesthesia or analgesia, and the patient's overall health and size.
Lots of factors to consider for dosing.
Absolutely. For example, lidocaine 1% or 1.5% might be used for blocks expected to last 2 to 4 hours. Bupivacaine 1% or 2% gives a similar duration. Bupivacaine 0.25% or 0.375%, or even 0.5% for dense block would be chosen for much longer duration. Epinephrine, 5-MLA, is frequently added to intermediate-acting agents to slow systemic absorption, prolong duration, and lower peak plasma concentrations. And again, peak plasma concentrations after nerve blocks are critical for safety. They depend on the total amount injected, the specific local anesthetic used, whether epinephrine was added, the blood flow to the injection site where intercostal blocks are highly vascular, and the surface area over which absorption occurs.
Absorption varies a lot by site.
Hugely. For example, injecting 400 milligrams of lidocaine without epinephrine for intercostal blocks might yield peak plasma levels around 7 ml, approaching potentially toxic levels, whereas the same dose for a brachial plexus block might only result in levels around 3 megaml. The maximum allowable dose must be adjusted downwards for blocks in more vascular regions or when performing multiple blocks simultaneously. Epinephrine can typically decrease peak plasma concentrations by 20–30%.
Okay, nerve blocks are precise but need careful dosing. What's a beer block? Sounds German.
Intravenous regional anesthesia, IVRA, often called a beer block after August Beer, who described it. It's a clever technique that relies on the limbs vasculature to deliver the local anesthetic to the nerve trunks and endings.
How does it work?
First, the extremity, usually an arm, sometimes a leg, is exsanguinated, meaning blood is squeezed out by wrapping it tightly with an elastic bandage, like an Esmarch bandage, from distal to proximal. Then, a pneumatic tourniquet placed proximally on the limb is inflated to well above the patient's systolic blood pressure, maybe 100–150 millirHg above. The Esmarch bandage is removed, leaving the limb pale and bloodless below the tourniquet. Then the local anesthetic solution is injected into a previously placed intravenous cannula, usually in a vein on the back of the hand or foot.
Injecting into a vein while the circulation is stopped.
Yes. The anesthetic solution flows retrograde through the venous system and then diffuses out into the tissues of the bloodless limb, reaching the nerve endings and trunks. Complete anesthesia typically develops within 5 to 10 minutes.
Quick onset, what are the downsides?
The main limitations are tourniquet pain, which becomes uncomfortable after about 30–60 minutes, and the potential for ischemic nerve injury if the tourniquet is left inflated for too long. Usually, inflation is limited to 2 hours or less. Safety is paramount. The tourniquet must remain inflated for at least 15 to 30 minutes after injection, even if the procedure finishes sooner, to allow the anesthetic to bind to tissues and prevent a potentially toxic bolus of drug from entering the systemic circulation when the tourniquet is eventually deflated.
Critical safety step there. What drug is used?
Lidocaine is the drug of choice, typically 40–50 milliliter of a 0.5% solution without epinephrine for an adult arm, or 0.5 milliliter we give in children. The maximum dose should generally not exceed 4 millitenk in adults.
Why no epinephrine?
It's not needed because the tourniquet prevents washout, and adding it could potentially worsen ischemia or cause systemic effects upon tourniquet release. The main advantage of a beer block is its simplicity and reliability for short procedures on the forearm hand or foot distal leg. Disadvantages include the limited anatomical regions where it can be used, the rapid return of sensation and pain shortly after tourniquet deflation, and the significant risk of systemic toxicity if the tourniquet is released prematurely or fails unexpectedly. Imagine 250 milligrams of lidocaine suddenly hitting the circulation that could easily cause seizures or cardiac issues. For this reason, bupivacaine is not recommended for beer blocks due to its cardiotoxicity and the fact it offers no duration advantage since the tourniquet determines the duration.
Okay, beer block. Simple for limbs, but tourniquet management is key. Now, moving centrally. Spinal anesthesia, injecting right into the spinal fluid.
Yes, spinal anesthesia, also called subarachnoid block or intrathecal anesthesia, involves injecting a small volume of local anesthetic directly into the cerebrospinal fluid, CSF, that bathes the spinal cord and nerve roots, typically in the lumbar space below where the spinal cord itself ends, usually around L1 or L2 in adults.
below the cord so you don't hit the cord itself.
Exactly. That's a key safety feature. Spinal anesthesia remains one of the most popular forms of anesthesia for procedures involving the lower abdomen, perineum, and lower extremities. Its main advantage is the ability to produce profound anesthesia and muscle relaxation over a considerable fraction of the body using very small amounts of drug, resulting in negligible plasma, local anesthetic levels, and thus minimal risk of systemic toxicity from the anesthetic itself.
Small dose, big effect, low systemic risk. Sounds good. What are the side effects then?
Most side effects of spinal anesthesia result not from the drug systemically, but from the intended local anesthetic block of the sympathetic nervous system fibers that travel within the spinal nerve roots, particularly those emerging from the thoracic and upper lumbar segments, T1L2.
Blocking the sympathetic nerves, what does that do?
Even when injected low in the lumbar spine, some cephalid, upward spread of the local anesthetic, occurs within the CSF, influenced by factors like patient position and the porosity of the solution, its density relative to the CSF. The sympathetic blockade often extends several spinal segments higher than the sensory blockade, as the preganglionic sympathetic fibers are quite sensitive to even low concentrations of local anesthetic. The most important physiological effects are on the cardiovascular system. Blocking sympathetic outflow causes vasodilation, particularly on the venous side, capacitance vessels. This leads to pooling of blood in the legs and splanchnic circulation, reducing venous return to the heart and thus potentially lowering cardiac output and blood pressure.
Hypotension is common.
Yes, some degree of hypotension is common. A low block, for example, only up to the lower lumbar segments, is usually well tolerated in healthy patients. But as the block level rises higher, the effect becomes more marked and venous return becomes increasingly dependent on gravity. A precipitous decline in cardiac output and organ perfusion can occur if venous return is significantly compromised. With a high block reaching the upper thoracic levels, T1, T4, the cardiac accelerator fibers that increase heart rate and contractility can also be blocked. This is particularly detrimental in patients who rely on elevated sympathetic tone to maintain circulation, for example, those with congestive heart failure or hypovolemia, as it removes their compensatory mechanisms. The rate of cardiovascular compromise can accelerate, and in rare cases, sudden bradycardia or even a systole cardiac arrest can occur, possibly due to the loss of sympathetic innervation, allowing unopposed parasympathetic vagal activity to the heart.
Wow. So managing blood pressure is critical.
Absolutely. Blood pressure is monitored closely as a surrogate marker for perfusion. Hypotension is usually treated when BP decreases by about 20-30% from resting values or becomes symptomatically low. The goals are to maintain brain and cardiac perfusion and oxygenation. Treatment options include administering supplemental oxygen, giving intravenous fluids, often a bolus of 500 to 1,000 milliliters is given preemptively, manipulating patient position, e.g. slight head down tilt, leg elevation to improve venous return, and using vasoactive drugs. Ephedrine, 5 to 10 milligram IV, has traditionally been a drug of choice due to its mixed alpha and beta adrenergic effects, increasing heart rate and causing venoconstriction. Direct-acting alpha-1 agonists like phenylephrine are also commonly used now, primarily causing vasoconstriction.
Okay, what about other effects of the sympathetic block?
An interesting, often beneficial effect is on the intestine. Sympathetic fibers, T5L1, normally inhibit peristalsis. Blocking these fibers result in unopposed parasympathetic activity, leading to a small, contracted intestine. This, combined with the flaccid abdominal musculature from the motor block, often provides excellent operating conditions for intra-abdominal bowel surgery.
Better surgical field. Any respiratory issues?
Direct respiratory effects are minimal unless the block is extremely high, reaching cervical levels, which is rare and undesirable. Effects are mostly mediated by paralysis of the intercostal muscles, muscles between the ribs, and abdominal muscles, which are important for forceful coughing and clearing secretions. This might reduce respiratory reserve or cause a sensation of difficulty breathing, dyspnea, in patients with pre-existing lung disease like severe bronchitis or emphysema. Respiratory arrest during spinal anesthesia is much more likely to be due to profound hypotension causing brainstem ischemia than direct paralysis of the pharynx nerves, which control the diaphragm and arise higher up, or toxic local anesthetic levels in the CSF.
So it's usually a circulation problem leading to breathing stopping.
More often, yes. Pharmacologically, the common drugs used for spinal anesthesia are lidocaine, often hyperbaric 5% solution for short procedures, bupivacaine, hyperbaric 0.75% or isobaric 0.5% for intermediate to long procedures, and tetracaine, often mixed with dextrose to make it hyperbaric for long procedures. Ropivacaine is also used. The height of the block achieved is influenced by several factors: the dose of drug injected, the volume and concentration used, the porosity of the solution, the speed of injection, and crucially, the patient's position during and immediately after injection. For example, keeping a patient sitting up after injecting a hyperbaric solution will tend to confine the block to the lower saddle area. Laying them down quickly will allow it to spread higher. Increasing the dose generally leads to a predictable increase in the block level needed for surgery. A GIO may be 100 mg lidocaine, 15-20 mg bupivacaine, or 10-12 mg tetracaine for a T4 sensory level block, suitable for upper abdominal surgery.
Porosity matters a lot for spread. Hyperbaric sinks, hypobaric floats.
Exactly. Hyperbaric solutions, made denser than CSF, usually by adding dextrose, will settle dependently according to gravity. Hypobaric solutions, less dense than CSF, perhaps by diluting with sterile water, will migrate upward against gravity. Isobaric solutions, same density as CSF, tend to stay more localized where injected, spreading slowly by diffusion. Choosing the appropriate porosity and carefully considering patient positioning are crucial for achieving the desired level of anesthesia safely and effectively.
Can you add epinephrine to spinals too?
Yes, epinephrine, or sometimes phenylephrine, is often added to spinal anesthetic solutions, primarily to increase the duration and sometimes the intensity of the block. Its effect on duration seems most pronounced and reliable with tetracaine, significantly prolonging the block. With lidocaine and bupivacaine, it might prolong the block more noticeably at lower dermatome levels, i.e. prolong the time until regression is complete, rather than significantly extending the time at the peak surgical level. The exact mechanism by which vasoconstrictors prolong spinal anesthesia isn't entirely certain. It was thought they decrease spinal cord blood flow, reducing washout of the anesthetic from the CSF, but this hasn't been convincingly demonstrated. An alternative or additional mechanism is that epinephrine and other alpha-adrenergic agonists, like clonidine or dexmedetomidine, which are sometimes added as adjuvants, may directly decrease nociceptive pain transmission in the spinal cord dorsal horn by acting on alpha-2A adrenergic receptors, contributing synergistically to the overall analgesic effect.
Interesting. Direct effect on pain pathways, too. What are the main complications of spinal anesthesia?
Serious complications are extremely rare, but they can occur. Neurological deficits can happen immediately or be delayed. Potential causes include contamination of the injected solution with foreign substances, like sterilizing solutions, ultrasound gel, glove powder, infection, meningitis, or epidural abscess, hematoma formation, spinal hematoma, especially if the patient has a bleeding disorder or is on anticoagulants, or direct mechanical trauma from the needle. Treatment for these is often ineffective beyond draining an abscess or hematoma, so meticulous aseptic technique and careful patient selection are vital for prevention.
Prevention is key.
Absolutely. There have been concerns in the past, particularly with highly concentrated 5% lidocaine solutions, especially those containing 7.5% glucose, about transient neurological symptoms, TNS, or even longer-lasting deficits, possibly due to neurotoxicity. This has led many practitioners to use lower concentrations or alternative agents like bupivacaine or ropivacaine. Whether to perform spinal anesthesia in patients with pre-existing progressive spinal cord disease is debated. It's often avoided out of caution, though there's little experimental evidence supporting the direct contraindication. It might be useful in patients with fixed chronic spinal cord injury. The most common sequela is post-dural puncture headache, PDPH. This is a postural headache. Worse when upright, better when lying flat, thought to be caused by leakage of CSF through the hole made in the dura by the spinal needle. Its incidence decreases significantly with patient age, less common in older adults, and the use of smaller diameter, specially designed pencil point needles, like Whitaker or Sprott needles, that spread dural fibers rather than cutting them. If PDPH occurs, initial treatment is conservative: bed rest, hydration, analgesics, caffeine. If that fails, an epidural blood patch injecting a small amount of the patient's own blood into the epidural space near the puncture site to plug the leak is usually highly effective.
The blood patch. Okay.
Overall, spinal anesthesia is a safe and effective technique, particularly for lower abdominal, lower extremity, and perineal surgery, often combined with intravenous sedation for patient comfort. Low spinal anesthesia likely carries less potential for harm than general anesthesia for many patients. High spinal anesthesia, intended for mid or upper abdominal surgery, is often less satisfactory and potentially less safe than either combining spinal with a light general anesthetic or using general anesthesia with neuromuscular blockade.
Okay, that's a comprehensive look at spinal. What about epidural anesthesia, injecting outside the dura? How does that compare?
Right. Epidural anesthesia involves injecting the local anesthetic into the epidural space. the potential space that lies outside the dura mater, the tough membrane surrounding the spinal cord and CSF, but inside the vertebral canal. This space is bounded by the ligamentum flavum posteriorly, the spinal periosteum laterally and anteriorly, and the dura mater medially. It contains fat, connective tissue, lymphatics, and a rich network of veins, the epidural venous plexus.
So, outside the spinal fluid space.
Correct. Epidural anesthesia can be performed via needles placed in the sacral hiatus, the opening at the bottom of the sacrum, called caudal epidural, or more commonly in the lumbar, thoracic, or even cervical regions, depending on the desired area of blockade. Its popularity has surged due to the development of flexible epidural catheters that can be threaded through the epidural needle and left in place. This allows for continuous infusions of local anesthetic or repeated bolus administrations, offering much more control over the duration and intensity of the block compared to a single-shot spinal. It's widely used for labor analgesia, post-operative pain control, and sometimes as the primary anesthetic for surgery.
Catheters make it adjustable. Where does the drug act from the epidural space?
The primary site of action is believed to be on the spinal nerve roots, as they traverse the epidural space after exiting the dura, but before passing through the intervertebral foramina. There may also be some diffusion across the dura into the CSF, acting directly on the spinal cord, especially with larger volumes or higher lipid solubility drugs, and some action on nerves in the perivertebral spaces via spread through the intervertebral foramina.
So, multiple potential sites. How do you choose the drug?
Drug selection for epidural anesthesia is similar to that for major nerve blocks, primarily dictated by the desired duration of action. Short-acting drugs like chloroprocaine or lidocaine can be used, or longer-acting agents like bupivacaine or ropivacaine. With a catheter, even short-acting drugs can be administered repeatedly or infused continuously for prolonged control. Bupivacaine, 0.5% or sometimes 0.75% for dense surgical block, is very common for long procedures. But crucially, remember, the 0.75% bupivacaine solution is generally not approved or recommended for obstetrical epidural use due to reports of enhanced cardiotoxicity and difficulty in resuscitation in pregnant patients should accidental intravascular injection occur.
Higher risk in pregnancy for the high concentration.
Yes. Lower concentrations of bupivacaine, like 0.25%, 0.125%, or even 0.0625%, often combined with a small amount of an opioid like fentanyl, are very widely used for labor analgesia or postoperative pain management, providing good sensory block with minimal motor block. Lidocaine, typically 2%, is the most frequently used intermediate-acting epidural local anesthetic. Chloroprocaine, 2% or 3%, provides a very rapid onset and very short duration, which can be useful, but its use has been controversial due to those past concerns about potential neurological complications if accidentally injected in large volumes into the subarachnoid space.
Okay, can you add epinephrine to epidurals too?
Yes, epinephrine, usually 5 big-ml 1.200,000, is frequently added to epidural local anesthetic solutions. It serves several purposes. It can prolong the duration of block, especially for lidocaine. It reduces systemic absorption and thus lowers peak plasma concentrations and potential toxicity, and it can serve as a marker for inadvertent intravascular injection. If the needle or catheter accidentally enters an epidural vein, the absorbed epinephrine can cause a transient increase in heart rate and blood pressure, alerting the anesthesiologist. This is called a test dose. Epinephrine can also modify the cardiovascular effects of the sympathetic blockade.
Multi-purpose additive in epidurals. How do volume and concentration affect the block?
Volume and concentration are key determinants of the epidural block characteristics. Volume. There's a general relationship between the volume injected and the segmental level of anesthesia achieved. For example, in healthy adults, it might take about 1 to 1.5 milliliters of 2% lidocaine per spinal segment to be blocked. Less volume is often needed in the elderly due to decreased epidural space compliance, and in pregnant patients, due to engorgement of epidural veins narrowing the space, while children require volume adjustments based on weight. Volume determines the spread, essentially. Concentration. This primarily determines the density of the block or which types of nerve fibers are blocked. Concentration. Highest concentrations, for example, 2% lidocaine, 0.5% bupivacaine, typically produce blockade of sympathetic, somatic sensory, and somatic motor fibers, resulting in complete anesthesia and muscle relaxation. Concentration. Intermediate concentrations, or every 1% lidocaine, 0.25% bupivacaine, usually provide good somatic sensory anesthesia, pain, and temperature block with minimal or no muscle relaxation. Concentration.
Low concentrations, eager to throw 0.125% or 0.0625% bupivacaine, often with an opioid, may block only the small preganglionic sympathetic fibers and some sensory fibers, providing analgesia, pain relief, with very little motor block, ideal for labor or postoperative ambulation.
So you can tailor the block density with concentration.
Exactly. The total amounts of drug used for epidural anesthesia are much larger than for spinal anesthesia, and the maximum safe total amounts are generally similar to those recommended for peripheral nerve blocks or infiltration anesthesia.
Is epidural harder to do than spinal?
Epidural anesthesia generally requires greater technical skill and experience than spinal anesthesia. Identifying the epidural space correctly by loss of resistance or hanging drop technique requires practice, and placing a catheter adds another layer of complexity.
Okay. What's the big difference in terms of systemic effects compared to spinal?
A key difference is systemic absorption. Because much larger doses of local anesthetic are used for epidurals compared to spinals, significant systemic absorption occurs from the highly vascular epidural space. This can lead to relatively high blood concentrations of the local anesthetic.
Higher drug levels in the blood.
Yes. For example, peak lidocaine levels might reach 3 to 4 beta-NO after a typical 400 milligram lumbar epidural dose. Peak bupivacaine levels might be around 1 beta-ml after a 150 milligram dose. Epinephrine 5 beta-ml can decrease these peak plasma concentrations by about 25%. Peak blood concentrations are primarily a function of the total dose administered, not just the concentration or volume used. Because of these potentially high blood levels, cardiovascular responses during epidural anesthesia can be prominent, even though there isn't the same kind of distinct differential sympathetic blockade zone seen with spinal anesthesia. The absorbed local anesthetic itself can directly affect vascular smooth muscle in the heart. Additionally, absorbed epinephrine added to the solution can cause beta-2 adrenergic receptor-mediated vasodilation and potentially hypotension, even while increasing cardiac output. The degree of systemic absorption also depends on the drug's properties. Less lipid-soluble agents like lidocaine tend to distribute more readily into the circulation compared to highly lipid-soluble agents like bupivacaine, which bind more avidly to epidural fat.
So systemic drug effects are more of a concern with epidural.
They are definitely a factor to consider, yes. High blood local anesthetic concentrations during epidural anesthesia are particularly concerning during labor and delivery, as local anesthetics readily cross the placenta and can potentially cause neonatal depression, irreparably decreased muscle tone, drowsiness, if maternal concentrations become too high near the time of birth. This risk is largely mitigated in modern practice by using more dilute solutions, like 0.125% or 0.0625% bupivacaine with fentanyl for labor analgesia, which minimize systemic absorption while still providing effective pain relief.
Using dilute solutions for labor epidurals makes sense. Finally, what about using opioids in the spinal or epidural space? How does that work?
Yes. Epidural and intrathecal opiate analgesia. This has been another major advance in pain management. The discovery was that injecting very small quantities of opioid drugs like morphine or fentanyl directly into the intrathecal, spinal, or epidural space produces profound and prolonged segmental analgesia without causing numbness or muscle weakness.
Opioids instead of or with local anesthetics.
Can be used either alone, particularly for postoperative or chronic pain, or more commonly now, in combination with very low concentrations of local anesthetic, like dilute bupivacaine, to achieve synergistic analgesia with fewer side effects from either drug class. This led rapidly to their widespread use in managing pain during surgery, postoperatively during labor, and for chronic pain conditions.
How do the opioids work there, different from local anesthetics?
Completely different mechanism. The analgesia produced by epidural or spinal opioids is primarily confined to sensory nerves entering the spinal cord dorsal horn near the level of injection. Opioids bind to opioid receptors located both presynaptically on the terminals of primary afferent pain fibers, inhibiting the release of pain neurotransmitters like substance P and glutamate, and postsynaptically on certain dorsal horn neurons involved in pain transmission, decreasing their excitability.
So they directly dampen the pain signals in the spinal cord itself.
Exactly. And unlike local anesthetics, conduction in autonomic nerves, non-pain sensory nerves, touch, pressure, proprioception, and motor nerves is not significantly affected by opioids at typical clinical doses used neuraxially. Therefore, blood pressure, motor function, and non-nociceptive sensory perception are typically not influenced. You get pain relief without the numbness or weakness.
Pain relief without the block. What are the side effects of neuraxial opioids then?
The most common side effects include inhibition of the volume-evoked micturition reflex, leading to urinary retention, difficulty urinating, which can be quite common, especially with morphine. Pruritus, itching, particularly around the face and trunk, is also very common, especially with morphine. Nausea and vomiting can occur. The most serious potential side effect is delayed respiratory depression and sedation, which can occur hours after administration, especially with morphine, due to slow cephalid spread of the opioid in the CSF, reaching respiratory centers in the brainstem. However, this occurs infrequently with the lower doses and more lipophilic opioids, like fentanyl, commonly used today, combined with careful patient monitoring protocols.
Respiratory depression is the big one to watch for.
It is, though less common now than in the early days. Clinically, spinally administered opioids alone are generally not sufficient to provide surgical anesthesia. They don't block sharp pain completely. They are most widely used for postoperative and chronic pain management. They provide excellent analgesia, for example, after major thoracic, abdominal, pelvic, or lower extremity surgery, often significantly reducing the need for systemic opioids and their associated side effects like sedation, confusion, and constipation. For dosing, spinally administered morphine, for example, 0.10, 0.3 milligram, can provide 8 to 16 hours or even longer of analgesia. Epidural catheters allow for prolonged analgesia with repeated boluses or continuous infusions, e.g. epidural morphine, 2 to 5 milligrams every 6-12 hours, or continuous fentanyl, 20-50 hr, often combined with dilute bupivacaine. As with systemic opioids, tolerance to the analgesic effects of neuraxial opioids can develop over time with chronic administration, usually managed by carefully increasing the dose or adding other analgesic modalities.
Wow. That covers a huge amount of ground on how these are used. What an incredible journey, seriously. From the accidental discovery of cocaine numbing a Kung, literally stumbling upon it, to the incredibly precise and detailed understanding we now have of how specific molecules interact with specific channels in our nerves. We've gone from basic chemistry, esters versus amides, hydrophobicity, to the really nuanced world of clinical applications, exploring everything from how pH affects a drug's journey across a membrane, to why certain anesthetics are chosen for childbirth versus, say, dental procedures or major surgery. You now understand the intricate dance between structure, mechanism, metabolism, and application.
It really is remarkable. If we connect this to the bigger picture, it truly highlights the astounding complexity and precision of the human body's signaling systems, and the equally remarkable ingenuity of pharmacology in learning how to interact with those systems. The ability to reversibly silence pain signals, to tailor the type and duration of numbness for specific needs, and to constantly manage that delicate balance of efficacy versus toxicity. It's a profound testament to decades, even centuries, of scientific observation and advancement. It shows how focused scientific inquiry can lead to a mastery over physical sensation, transforming medical practice and improving countless lives.
So what does this all mean for you, listening in? You now have a much deeper understanding, hopefully approaching that elite professional level we aimed for, of the mechanisms, the historical context, the chemistry, and the diverse clinical uses of local anesthetics. The next time you encounter that feeling of numbness, whether at the dentist or for a minor procedure, or maybe even helping someone manage postoperative pain, you'll know the incredible science working behind the scenes to make it happen safely and effectively. And this raises an important question, maybe, for you to ponder. What else do we take for granted in our daily lives, in medicine or elsewhere, that has such a rich history and intricate, often invisible science behind it? Keep exploring, keep questioning, and keep diving deep. We'll catch you on the next deep dive.